Hello, everyone. Thank you for joining us today. My name is Tanya Nash, CDC Excel Project Manager at the Allergy and Asthma Network, and I'm delighted to welcome you to this afternoon's CME accredited webinar. We have a special presentation for you today focused on tailoring therapies to meet the needs of severe asthmatic patients. Before we start today's program, I'd like to cover a few housekeeping details. First, everyone will remain muted during the webinar to minimize distractions. We will record the session and upload it to our website in about 1 week. You can watch all of our recorded webinars at allergyasthmanetwork.org. Our webinar is scheduled to last 1 hour. There will be a Q&A session after the presentation. You can send your questions to us using the Q&A box at the bottom of your screen. A team member will check the chat for any questions or help you need. We will do our best to answer as many questions as possible before we finish. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. The college offers continuing medical education credits for physicians and attendance credits for others. You can create a free account to earn CME or attendance credits for Advances webinars via the member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you will receive an email containing supplemental resources and a link to download your certificate of attendance. We will share the link to the certificate of attendance in the chat towards the end of the webinar. Next slide. Today's presentation is titled The Severe and Controlled Asthma, Tailoring Therapies for Complex Patients. While many individuals with asthma may achieve good control, some continue to struggle with persistent symptoms and frequent exacerbations despite appropriate treatment. These complex cases require us to look deeper, considering phenotype, biomarkers, comorbidities, and individualized treatment strategies. With that, it's my pleasure to introduce today's speaker, Dr. Leonard Bacharier. Dr. Bacharier holds the Janie Robinson and John Moore Lee Chair in Pediatrics and is a professor of pediatrics at Vanderbilt University Medical Center. He serves as the section chief of Pediatric Allergy and Immunology, scientific director of the Center for Clinical and Translational Research, and director of the Center for Pediatric Asthma Research. As a pediatric allergist and immunologist, he has extensive experience in pediatric asthma research, especially in clinical trials. He has led and participated in numerous federally funded multi-center clinical trials in childhood asthma, resulting in over 300 peer-reviewed manuscripts from these projects. Dr. Bacharier is the only American pediatrician on the Global Initiative for Asthma Science Committee. He is also the secretary and treasurer of the Quad AI, an associate editor for the Journal of Allergy and Clinical Immunology, and editor of the 2 leading textbooks in the field of allergy and immunology. Thank you for being here, Dr. Bacharier. I'll turn it over to you.
Great. Thanks, Tanya. Good afternoon, everybody. Appreciate the Allergy and Asthma Network inviting me to participate in this very well-received webinar series, and to everybody for taking some time out of the middle of what I'm sure is a very busy early spring day to talk a little bit about how we are approaching our patients with the most challenging degrees of asthma. Here are my disclosures relevant to today's discussion, and it is I'm going to spend a fair amount of time talking about biologics, and I have had interactions with all of the manufacturers of these products. We have 3 objectives for today's discussion. First is to define and differentiate what we mean by severe and uncontrolled pediatric asthma, then talk a bit about how to evaluate and interpret type 2 biomarkers in an effort to better phenotype our patients and then lead to biomarker and phenotype-driven care. And then finally, to apply the evidence that we now have from pediatric trials that allow us to individualize and personalize the care that we provide these patients. So in order to talk about the management of severe asthma, we first have to come to agreement as to what we mean by severe asthma, and that's a much more challenging effort than might be expected, because we really don't have a consensus definition as to what severe asthma is. Two leading sources in this area, the Global Initiative for Asthma and the guidelines put forth by the ERS and ATS, have attempted to do this for us. And it's really based on the amount of therapy required for a given patient. And this generally means step 4 or 5 level therapy, medium or high dose inhaled corticosteroids, often with secondary controllers, that are either effective in achieving disease control, but disease control lapses when these medications are reduced or withdrawn, or despite use of this high intensity therapy, asthma remains uncontrolled. Furthermore, the ATS-ERS guidelines also suggest that if you require systemic steroids for at least half the year and your asthma in order to maintain or inadequate to maintain control, that your asthma would be severe. I personally think that 50% is way higher than what would define severe asthma in the current age, and certainly patients who require frequent oral steroid bursts might very well meet this definition. So, as we've learned over time, there is no one form of asthma. There are a variety of subforms of asthma. We call these asthma phenotypes. We call these patterns of asthma. And this has become important as we have now developed therapies that only work in specific subtypes of asthma. So in order to really understand these, it's worth taking a half a step back and looking at what we mean by these asthma phenotypes. And one good example of this is what was done in the NIAID's APIC study, which was an observational study of children 6 to 17 years of age who lived in American inner cities, who had a physician diagnosis of asthma, but could enter regardless of asthma severity. It was a 12-month prospective trial or study. Every child received standardized guideline-based care for both asthma and rhinitis, with medications provided to the patients. And they were evaluated every 2 months, and treatments were adjusted based on levels of disease control using a standardized approach. And they defined asthma in 3 different ways based on the amount of therapy required for the disease. Children were considered to be easy to control if they required 50 micrograms or less of fluticasone, montelukast only, or no controller. They were considered difficult to control if they required at least 250 micrograms twice a day of fluticasone with or without a LABA. And they were considered indeterminate if they were anywhere in between these two, because the real contrast was between early, easy to control, and difficult to control. And then using clustering analysis, we asked the computer to put children of like patterns together. And what we found is that in this group of unselected children with asthma, they could actually be categorized into 5 different patterns of disease. And I really want to focus our attention on a few of these. What you'll see here is a heat map. The lighter the blue means the lower the value for a given feature. The darker the blue, the higher that value. And what you see is indicators or markers of asthma severity, lung physiology, rhinitis severity, allergen sensitization, and markers of allergic inflammation based on blood eosinophil count and FeNO levels at study entry. The first thing we see is that there are 2 groups who have an awful lot of what we call type 2 high inflammation, meaning that their blood eosinophil counts are high and their FeNO levels are generally high. But what you see is that just because you have a high blood eosinophil count or a high FeNO doesn't mean you have comparable degrees of asthma severity. The children in Group E had the most severe asthma. They had the highest score of, as it related to albuterol use, exacerbation frequency, extent of controller needed. They had the lowest degree of lung function. They had substantial dilator response. They had high levels of rhinitis. They were sensitized to a large number of allergens. They had a high IgE level. But there's another group of children who had very similar degrees of type 2 inflammation, very similar extent of allergic sensitization, but their asthma is actually pretty mild. They did not need nearly as much albuterol. Their exacerbation frequency was less than half of what it was for Group E. They had better, although not entirely normal, lung function. So even in those who have type 2 high asthma, they're not all the same. One-third of them had most severe form, but two-thirds of these type 2 highs had less severe asthma despite having markers of type 2 inflammation. Contrast this to Group B. This group had the least amount of type 2 inflammation. They had low levels of pheno, they had low levels of bloody eosinophils, they were sensitized to 2 aeroallergens in contrast to 14. But look at their asthma severity indicators. They look a lot more like Group E children than Group D children. So these children have substantial amounts of asthma without a type 2 signature. So we call these children type 2 low. And then there were a couple other groups, one group that had very mild disease in all forms, and one that had a modest amount of atopy, but still very mild asthma. So we look to our national and international guidelines to help guide our thought process on how to manage patients with moderate to severe asthma and who are more difficult to control. And this is the stepwise approach that is in the GINA 2025 document. I will alert you that on World Asthma Day in early May, GINA 2026 will be released, and I encourage you to watch out for that. But what we see is that, the management of asthma is this sort of arrowed circle of assess, adjust, and review. And this gets overlooked a lot when we look at a slide like this. People jump right away to what medicine should I use? But in order to get the medication right, we have to assess the patient correctly. We have to see them regularly and adjust. And the review is essential because this is not a static disease, it is dynamic. And what was adequate at one point in time may not be adequate at any further point in time. Our discussion today is going to focus on children who, despite medium dose ICS/LABA or maintenance and reliever therapy, remain uncontrolled. And the GINA suggestion is that they be referred for expert management that will include phenotypic assessment, consider a trial of higher dose inhaled corticosteroid therapy, but that is generally ineffective in children who are already receiving medium dose, and consider add-on therapy with biologics, and only as a last resort, consider add-on chronic low-dose oral steroids. But in 2026, this should be an exceptionally rare event. So when we talk about asthma phenotyping, what does that really reflect? Or what does that really require? It's about assessing phenotype when patients are on high intensity therapy or their lowest possible dose of oral steroids. And the markers that have borne out as indicators of underlying type 2 inflammation, in other words, type 2 high asthma, include any of the following: bloody eosinophil count of at least 150, a pheno of at least 20 parts per billion, a sputum eosinophil count, if anybody is doing that, of at least 2%. If asthma is clinically allergen driven, or for patients who require maintenance oral corticosteroids, these factors may not be detectable because oral steroids are very effective in driving down all of these measures. But it's also important to remember that that these factors are also dynamic over time, and that a single measure may not capture a patient's underlying type 2 inflammation adequately. And thus, we recommend that this may be repeated up to 3 times on the lowest possible oral steroid dose and as far removed from a course of oral steroids as possible, with studies showing that oral steroids can affect eosinophil counts for weeks to months in some patients. So, keeping that in mind is essential in determining whether a patient has underlying type 2 airway inflammation. So now let's turn our attention to the management side of things with our biologic agents. And what we have here is the typical confusogram of a variety of cell types essential in the inflammatory pathways that characterize many patients with childhood asthma. It's important to note that all of the biologics that we're going to talk about today are really intended for children who have type 2 high asthma. There's only one approved for children over 12 that has ever demonstrated efficacy in patients who don't have evidence of type 2 inflammation. We'll talk about that briefly, but really this collection of agents is focused and targeted to patients who have evidence of type 2 inflammation. We'll talk about each of these as we go. So at present, in children 6 and above, and I'm really focused on the 6 to 11 age group, the FDA has now approved 4 biologics for children with type 2 high asthma. The first and the one that was approved earliest was omalizumab. This is a monoclonal antibody against IgE. It binds free IgE in circulation, thereby preventing it from binding to its receptor on the surface of mast cells and basophils. IgE that is not bound to mast cell or basophil surfaces has no biologic activity, and thus this reduces the effects of allergen on driving an inflammatory response. Mepolizumab is a monoclonal antibody against IL-5. IL-5 is a cytokine produced by type 2 cells that is essential for the growth, development, differentiation, and survival of eosinophils, an essential cell type in type 2 asthma. By binding IL-5, it prevents IL-5 from interacting with its receptor. This effectively starves the eosinophil. It removes its essential growth factor and leads to marked reduction in eosinophil numbers after administration. The third agent is benralizumab. This is an anti-IL-5 receptor antibody. So instead of binding to IL-5 in circulation, it binds to the receptor for IL-5 on the surfaces of eosinophils. After binding, it attracts other immune components that lead to the death of these eosinophils. So it results in the rapid depletion of whole body eosinophils and its downstream effects. Finally, there's dupilumab, a monoclonal antibody directed against the IL-4 receptor alpha chain. This IL-4 receptor alpha chain is a shared component of receptors for the cytokines IL-4 and IL-13. IL-4 is an essential cytokine to tell B cells to class switch to produce IgE, the antibody essential for allergic inflammation, and is a shared component of the receptor for the cytokine IL-13, which is important in mucus production, nitric oxide synthesis, and other components of airway inflammation. And this monoclonal antibody blocks those downstream effects. And we'll talk about the clinical outcomes related to these therapies as we go. So we're now very fortunate that we actually have a robust data set of use of these agents in clinical trials in children that really do help guide our understanding as to who do they work for, how well do they work, and what should our patients expect. And I'm going to spend a bit of time talking about 2 of the larger trials that we've had the opportunity to be part of, because I think they're really informative in teaching us where these agents fit in and what to expect from them. We'll start with omalizumab, the anti-IgE antibody. This is one that's been around the longest. I highlight here data from the ICATA study from the Inner City Asthma Consortium that showed that addition of omalizumab to standard asthma care in inner city American children reduced the risk of exacerbation from 50% in the placebo group to about 30% in the omalizumab treated group, and that it nearly eliminated these seasonal peaks of exacerbation that we all are well aware of in the fall and spring. So omalizumab is effective in reducing the risk of exacerbation in children with severe allergic asthma. If there's no evidence of allergic sensitization, omalizumab is not to be effective in that subgroup. Mepolizumab, the anti-IL-5 antibody, was originally approved in patients 12 and above and subsequently extended to children aged 6 to 11 in an open label pharmacokinetic study that supported comparable pharmacokinetics to that seen in adults. But we still didn't have a real good sense as to how effective this therapy was going to be in children with eosinophilic asthma. So we conducted the Muppets 2 study in the Inner City Asthma Consortium. This is a double-blind randomized placebo-controlled trial of children 6 to 17 years of age living in urban centers in the United States who have difficult to control asthma, have had at least 2 prednisone-requiring exacerbations in the past year, and who have evidence of eosinophilic asthma reflected by a blood eosinophil count of at least 150 cells per microliter at baseline. Children were maintained for 4 weeks on their standard of care and then randomized to have either mepolizumab or placebo once a month injected subcutaneously on top of guideline-based asthma management for 1 year, with our primary outcome being the number of asthma exacerbations between the two groups. To give you a sense as to what this study population looked like, we randomized 290 children, 146 to mepolizumab, 144 to placebo. What you can see is that a third of them had a BMI in excess of 95th percentile. There was evidence of type 2 inflammation in that their phenos were around 30 to 35 parts per billion. Their blood eosinophil counts were 400 to 455. Their total IgEs were around 400. And they were sensitized to multiple allergens, 7 or 8 allergens per child. 97 to 93% also had a positive skin test to at least one inhalant allergen. Not unexpectedly, despite them having very severe asthma with type 2 markers, their lung function was actually well preserved, 92 to 94% predicted for baseline FEV1, with slightly lower FEV1 to FVC ratios, but significant airway reversibility. 2/3 of them were receiving high-dose ICS therapy, and they averaged almost 3 oral steroid bursts per year in the year prior to episodes. So these children clearly have severe eosinophilic type 2 asthma, although they do have quite well-preserved FEV1s. What did we find? After administration of mepolizumab, we saw a rapid reduction. This is total blood eosinophil counts from a baseline of about 400 to around 100, and this was maintained over the duration of the study. In the placebo group, the total eosinophil count did not change over the duration of the study. We looked at eosinophils in nasal washes and also saw that mepolizumab resulted in a significant reduction in upper airway eosinophils in a manner greater than what was seen in placebo. So mepolizumab clearly reduced eosinophil burden in these children. Here's the primary outcome, the rate of asthma exacerbations requiring oral steroid emergency visit or hospitalization, mepolizumab group in blue, placebo group in red. What you see is that the rate of exacerbation was higher in the placebo group and lower in the mepolizumab group. This resulted in about a 27% reduction in the rate of exacerbation, a statistically significant and clinically meaningful effect. However, we were surprised because in the studies of mepolizumab in adults, the rate of exacerbation reduction was closer to 50%. So we saw a reduction of about half of what we were expecting, and we really needed to better understand why it was that these children did not respond as well as we had expected. Maybe it was chance, maybe it was their inner city environment, maybe it's something else. But this was a less robust effect than we had anticipated. So we looked at secondary measures to see if it gave us some other insight as to what effect mepolizumab had. We looked at the Composite Asthma Severity Index. This is a score that integrates symptoms, albuterol use, controller medication step, lung function, and exacerbations. And we saw that it went down, i.e., got better in both groups and did so very similarly with no difference between mepolizumab treated children and placebo. We looked at FEV1 percent predicted and saw no difference at all over the duration of the study between mepolizumab treated children and placebo for FEV1, nor did we see differences for the FEV1 FVC ratio or measures of airway resistance done by impulse oscillometry. So no lung function impact of this therapy. So, we saw a reduction in exacerbations, but no meaningful impact on secondary outcomes. But indeed, effective in reducing exacerbations in children with eosinophilic asthma. Benralizumab, the monoclonal antibody against the IL-4 receptor alpha chain, was FDA approved based on data in adults, and this pharmacokinetic study in children showing comparable blood levels of the monoclonal antibody in children as we're seeing in adults. There was no placebo group here, so we really to date don't have a sense as to the magnitude of clinical effect that will be seen with this in children. In practice, there is an ongoing clinical trial that will attempt to answer that question, but at the moment, we cannot provide an estimate for exacerbation reduction with benralizumab in children. Dupilumab's the monoclonal antibody against the IL-4 receptor alpha chain. We studied this in two sequential studies, Voyage, an open double-blind placebo-controlled randomized trial of dupilumab versus placebo dosed in a weight-dependent fashion every 2 weeks for 1 year. At the end of that trial, children were offered the opportunity to enroll in the excursion study, which was an open label extension for an additional year, and the vast majority did so. And we'll talk about both of these results. For Voyage, we enrolled children 6 to 11 years with physician-diagnosed persistent, moderate to severe asthma. They had to be on medium dose ICS with a second controller or high dose inhaled steroid with or without a second controller. They had to have an FEV1 no higher than 95% predicted and a bronchodilator reversibility of at least 10%. They needed at least one severe exacerbation in the prior year, and they had to have evidence of uncontrolled asthma. The primary study population of interest were children who had a type 2 inflammatory phenotype. These are children who had a blood eosinophil count of at least 150 or a pheno of at least 20 parts per billion. We enrolled children irrespective of these, but the primary analysis was done in children who had a type 2 phenotype. But we also looked at those who had a blood eosinophil count a little on the higher side of at least 300 cells per microliter. And these children are very similar to the ones we saw in the Muppets 2 study, with a couple of exceptions. This international study enrolled nearly all white children. There were very few children other than Caucasians in this study. Unlike what we saw in the Muppets 2 trial, the lung function amongst this population was actually more compromised, with an FEV1 in the high 70% range. Comparable levels of bronchodilator reversibility, poor asthma control as assessed by the Asthma Control Questionnaire, significant degrees of type 2 inflammation. Their type 2 biomarkers, their eosinophil count is 5 to 600. Their IgEs were 4 to 500. Their phenos were around 30 parts per billion, and more than half had a pheno of at least 20 parts per billion. So another group of children with type 2 high uncontrolled asthma. Here we saw that there was a significant reduction in the rate of asthma exacerbations, very similar type of outcome to what we saw in the mepolizumab trial, but the magnitude of effect here was significantly greater. In the children who had that type 2 phenotype, EOs of at least 150 or a pheno of at least 20, we saw a 59% reduction in the rate of exacerbation. In those who had an eosinophil count of at least 300, we saw 65% reduction in the rate of exacerbation. Even using just a blood eosinophil count of 150 showed a 61% reduction. And in the population as a whole, irrespective of baseline biomarkers, we saw a 54% reduction in the risk of exacerbation. So significant reductions in exacerbation rates favoring dupilumab. We looked at improvement in lung function. As you recall, in the mepolizumab trial, there was no effect over placebo. In this trial, there was for both the type 2 phenotype and those with blood eosinophils of at least 150. These children improved 5 FEV1 percentage points over placebo in both of those groups. And in children who had the highest FeNO levels, those 20 parts per billion, irrespective of their eosinophil count, actually had an improvement of 6.74 percentage points of FEV1 over placebo. If we look at lung function over time, focus on the left here. These are children with the type 2 phenotype. In gray is the FEV1 pre-bronchodilator in the placebo group. You see that it does improve after 2 weeks and then is maintained over the duration of the 52-week trial. Whereas the children who received dupilumab have a greater improvement that is detectable by 2 weeks after the first dose, that continues to improve to week 12 to that 5 percentage point advantage, and that this is maintained through the duration of the study. Very similar pattern in children who had an eosinophil count of at least 300. If we look at asthma control, based on the asthma control questionnaire scores, we also see differences in favor of dupilumab-treated children with improved ACQ scores in both the type 2 phenotype and in those with blood eosinophil counts in excess of 300. As I mentioned, after the double-blind study, all children were offered the opportunity to participate in an excursion, where those who were on dupilumab during voyage were continued on dupilumab, and those who were on placebo during voyage were started on open-label dupilumab. Again, this was given in a weight-based fashion, and they were followed for an additional year. And what we saw is that the rate of exacerbation continued to go down in children, regardless of whether they received dupilumab during voyage in blue, or whether they received dupilumab or received placebo during voyage and were switched to dupilumab. I should point out that excursion was done during the early parts of the COVID pandemic, so there was a bit of a COVID effect here in the reduction of exacerbations. But when we looked at children who were in excursion pre-COVID rather than during COVID, we realized that the COVID effect was pretty minimal on the reduction of exacerbations. In the lower panel, we see the effect of dupilumab therapy on lung function. Here's the dupilumab-treated children for the first year in voyage and continuing on dupilumab, and we see a continued advantage in terms of FEV1 percent predicted. I want to point out, though, that in the placebo group, as soon as they start on dupilumab, their lung function goes up, which is very encouraging. And it stays up throughout the duration of the study, but it never quite gets as high as the children who started on dupilumab a year earlier. And this makes us wonder if this additional year of undertreated type 2 inflammation and ongoing exacerbation led to some degree of irreversible airway damage that was then no longer recoverable with the addition of dupilumab. Tezepelumab is an anti-TSLP monoclonal antibody. I didn't talk much about this because it's only approved for 12 and above, and we don't have an awful lot of data on its efficacy in children above the age of 12 years. But what has been seen is that there is a reduction in exacerbations and an improvement in lung function in patients receiving tezepelumab over placebo. So one of the real challenges in trials of biologics in childhood asthma is a very pronounced effect of diversity. As I mentioned earlier, the Voyage trial was done largely in Caucasian individuals, whereas the Muppets 2 trial was done in children in inner city America, where the vast majority were Black or of African American race. And it really speaks to the importance of trials to target minoritized populations. These have been done in other spaces and really do require close attention and an intentional effort to enroll the most diverse populations possible so that the results are most generalizable. So to summarize the efficacy of biologics in children with severe asthma, we see that of our four major biologics, here are their effects on lung function. They range from 27% to 59%. These are not head-to-head comparisons. It's not to say that had they been compared head-to-head, this is what we would have seen. But there is a variation and a variability in the extent of exacerbation reduction in the trials that we have. When we look at lung function effects, we see that the anti-IgE and the anti-IL-5 studies did not demonstrate meaningful effects in terms of FEV1, whereas the dupilumab trial did demonstrate a 5 percentage point increase. We need more trials in children. Fortunately, we now have some. I've reviewed the largest ones with you today, the Muppets 2 and the Voyage study, but there's still very inadequate amounts of data, particularly in adolescents for almost all of these biologics. And real effort needs to be paid to better study and better include these children in future efforts. How do we know which children are going to respond? We use biomarkers. And what we've seen is that these biomarkers are actually quite good at identifying children who are going to have benefit from these biologics. Here are some data from the omalizumab trial showing that even though this drug targets IgE, your blood eosinophil count and your FeNO are predictors of exacerbation benefit, such that an eosinophil count of over 20 of at least 2% or a FeNO of at least 20 parts per billion is associated with twice the likelihood of an exacerbation benefit with omalizumab. In a similar pattern was seen in patients, in adult patients, in terms of eosinophil counts as a predictor of response to anti-IgE. So it isn't just the target of the drug that predicts the response. It's the underlying extent of type 2 inflammation that really does seem to matter. When we look at mepolizumab in adults, there's a very clear relationship that as your blood eosinophil count goes up, your magnitude of reduction of exacerbations goes up as well. Unfortunately, in children in the Muppets 2 trial, we did not demonstrate that effect. There didn't seem to be a clear relationship between blood eosinophil count and extent of reduction. If you were 150, you were not all that different than if you were 200 or 350. For dupilumab, we saw that both FeNO and blood eosinophil counts are able to predict the response to dupilumab therapy, with higher levels of each of these being associated with greater response. But the converse was not true, as if children had no evidence of type 2 inflammation, i.e. blood eosinophil count under 150 and FeNO less than 20, there was a very low likelihood of an improvement. And here we see no effect on either exacerbations or lung function in children who had low levels of both biomarkers. But in contrast, as the biomarkers go up over 150, the magnitude of effect on reduction of exacerbations or improvements in lung function exists such that as children with higher blood eosinophil counts or higher FeNO derive greater benefit from dupilumab than those who have lower levels. So here's a flow chart. There are many of these available that talk about how to choose between biologics for a given patient. They start with identifying your patient as difficult to control, trying all the other non-biologic step-ups after you've confirmed the diagnosis, adherence, inhaler technique, environmental exposures, and comorbidities. And once you have severe uncontrolled asthma, you then phenotype your patient based on their blood eosinophil count, their FeNO, their allergic status, and their lung function. And then we subdivide them based on those factors. Blood eosinophil count under 150, blood eosinophil counts 150 to 1500, and blood eosinophil counts in excess of 1500. We then subcategorize them based on whether their phenos are below or above 20 parts per billion. And then we subcategorize based on whether the asthma is considered allergic or non-allergic. And then we think about which of the agents based on these categories have shown to be effective in those spaces, and you can see those here. But I also want to remind you that these are agents that have other effects in other type 2 disorders, such that there are patients who are going to have coexisting conditions. And some of these biologics work in multiple conditions, such that if you have a patient who has, say, atopic dermatitis, asthma, you might choose a biologic like dupilumab, which is effective for both of those. Or you have a patient with food allergy and allergic asthma, you might think about omalizumab as a preferred treatment option because you're able to um, target two diseases with a single intervention. Here's another table that really says the exact same thing, but just divides the patients up based on whether they're allergic or non-allergic, based on their blood eosinophil count, using the same cutoffs and using pheno. And you see the options here all presented in alphabetical order because we don't have head-to-head comparisons to say that one is definitively better than the other. Here's a general table that summarizes these agents, who they're approved for, what they're effective in. They're all given subcutaneously, all approved for home administration. Dosing frequency varies based on the agent, the age, the weight, and in the setting of omalizumab, the total IgE level. You can see that they vary based on their eosinophil thresholds, with mepolizumab and dupilumab being around 150 and benralizumab generally being a bit higher, around 300. Biologic therapy in children really is a great place to use shared decision-making approaches where you are able to better identify patients' beliefs, goals, and preferences and discuss asthma as it applies to that patient and that family. Patients' goals may not totally align with our goals, and every family has a different viewpoint. So I think it's essential that we present all options favorably and fairly. We be candid about injections and offer strategies to reduce anxiety and discomfort. I will tell you there are a lot of families that are slow to start, but I have not yet had a family that stopped because of the injections. So I don't think this is as big a barrier as we might think it would be, because these are children whose asthma is difficult to manage, and these are very frustrated families who are willing to do more to help their children lead healthier lives. A few practical aspects around biologics. This is very much unlike immunotherapy. These are all fixed doses. There's no adjustment needed for missed or late doses. There is home administration approved for all of them, but some of them have some differences. Some come as auto-injectors, some come as standard syringes, some come as either. Epinephrine auto-injector, based on the black box warning, remains required for patients receiving omalizumab therapy. Is essential to follow administration guidelines to minimize injection site reactions. In particular, dupilumab, which, if not allowed to come to room temperature, really does sting. So we really encourage them to let this come to room temperature before administering it. And even though we use biomarkers to start and initiate and choose therapy, they really aren't helpful in monitoring therapy. So unless there's a suspicion of side effects or other issues, we generally do not recommend routine monitoring of blood eosinophil counts or IgE levels, or pheno for that matter. How do we assess if it's working? We see our patients back regularly. A lot of patients stop coming back because these medicines work so well that they don't think they need us anymore, but they do. So I recommend that we see them every 2 to 3 months, and we assess response at 4 to 6 months. These drugs take a little bit of time to work, so I would not make any decisions about responsiveness early on. What we saw is that the best of these agents reduce exacerbation rate by 50 to 60%. That means that there are going to be patients who continue to exacerbate on these agents, and therefore an exacerbation does not reflect an inadequate response. Multiple exacerbations probably do, but a single exacerbation is absolutely not inconsistent with a response. But what are we looking for? We're looking for exacerbation reduction. We're looking for symptom improvement. We're looking for a reduction in rescue med use. We want to reduce, ideally eliminate oral steroids. We want quality of life to be better. We want healthcare utilization to be better. And we want lung function to be better. Not everybody gets all of these, but many to most patients get a reasonable number of these. If they're doing well, continue. If they're doing so-so, continue for up to 12 months if they're partial responders. If there's clearly no efficacy, and occasionally we see that, we recommend switching to an alternative agent of a different mechanism of action. In the vast majority of patients, you'll find a biologic that gets the job done for them, but it may not always be the first one you choose. Even if you use those algorithms religiously, occasionally the patient's disease behaves differently than you would have expected. So what we've seen today is that there are many phenotypes of asthma, and their biologic pathway that drives them, we understand some, but we don't understand all. We have a handful of biologics approved for asthma in children and adolescents. They really all target type 2 inflammation. They all lead to reduction in exacerbations. Their effects on both lung function and biomarkers, though, are a little less consistent. We continue to have no head-to-head comparisons of these agents to date, and I don't think we're going to have very many of these at any point in the future. There are indirect treatment comparisons and network meta-analyses that have been done. Their results are generally inconsistent as well and are really focused on data in adults, so they really don't help guide our thinking in children. And, we really do need more research in this space, and we need studies that further help us understand how to choose between the agents, because many of these patients have what we call overlapping phenotypes. If you have an eosinophil count of 300, there are at least 3 agents that we could choose for any of those patients. How do we know which one is the right one for that given patient? We really don't. We're learning, but we still have a long ways to go. So I want to remind you that the Global Initiative for Asthma has a lot of really wonderful resources, including the strategy report, our summary guide, our severe asthma guide. Here's a QR code to help get you there. Their slide sets, their podcasts. And like I said, in May, we will have an updated version in 2026, taking into account all of the developments that have occurred in the last year. So at that point, I again want to thank Asthma and Allergy Network for inviting me to talk with you today, and glad to open it up for some questions. Thank you.
Thank you, Dr. Bacharier, for the excellent presentation. The information that you shared with us today provides great resources for severe asthma management. We have several questions, and we will try to get to as many as we can before the end of the webinar. So let's start with this first question that we received early on in the presentation. At what stage of asthma should we use biologics? And how optimistic should we be about the results?
So it's a really important question. All of our studies to date have been in patients who have pretty substantial and advanced asthma. And it's actually remarkable to me how well these agents work in those patients. I suspect they work very well in patients with less severe disease. But given the cost considerations and the administration considerations, they are generally reserved for patients with more severe disease. We don't understand yet if these agents alter the disease at all. In other words, if a patient were to start on these therapies earlier, would their asthma be less severe for a lifetime? Would they be able to come off these agents? Would their asthma just lessen in severity? We don't know the answer to any of these questions. Clinical experience tells us that many patients do very well, and we've been able to stop biologics in many patients because of their excellent lack of disease progression. We don't know if that's because the biologic changed their disease or their biologic kept their disease quiet while it was getting better on its own, because a lot of children with asthma do just that. So I think we have still an awful lot to learn about when, where, and for how long we should be using these agents. But I think the findings from the Voyage and Excursion study remind us that delaying these therapies can have consequences in that those children who started on dupilumab a year later because of the clinical trial did not gain back as much lung function as the children who started it a year earlier. So we don't know if that applies to all of them. We don't know if that was just a unique population, but it does bait the question, does timing within the disease matter? And I think the answer is it probably does.
All right. And actually, you kind of responded to some of the questions that our next person had asked, which is, do you see a time when biologics would be first line therapy for children with moderate to severe asthma? It seems that lung preservation is likely key here, even with treatment with ICS. And do you have any information on weaning biologics?
Yeah, I think we touched on most of that. I think
Mm-hmm.
time will tell. I think the cost and administration issues are going to keep these agents at the higher levels of severity for the foreseeable future. That may not be the best biologically driven answer, but I think that's the reality of it. Um, and weaning has been unstudied in children. In adults, it's been studied pretty well, and it doesn't work. When you remove these agents in adults with type 2 asthma, they get worse. In children, many of us are hopeful that keeping the disease quiet for a period of time might be followed by a period of time where you might be able to do this. And I think this is completely off label, but it requires this is the art of medicine and shared decision making. Patient doing super well, no exacerbations for years, normal lung function, can't recall the last time they needed a bronchodilator, certainly hasn't needed a course of oral steroids for an extended period of time. You could think about strategies of both reducing their background non-biologic medicines, but then potentially spacing out the frequency with which you administer the biologic versus stopping it. We don't have a clinical trial driven approach for that. So this is sort of a good discussion to have with your patients and come up with a strategy and see if it works. And if it doesn't work, you just go back to where you were, which was working. So, these are medicines. They have an on effect and they have an off effect.
Hey, next question. To what extent do you find asthma diaries useful when managed by parents or older children versus being used primarily by primary care providers to inform that a specialty referral might be appropriate? If you considered invaluable, what key data elements would provide the most insight for developing an optimal treatment plan?
Yeah, I think they have value in the right hands. I will tell you that most families have limited motivation to diary their children's asthma symptomatology. I like them in people where folks can't really estimate how often they're symptomatic, how often they're using albuterol, or where I think what they're telling me seems inconsistent with what I'm seeing. So I think albuterol use, I think nighttime awakenings, I think are probably the two most important diary elements if you're going to use them. Um, there are electronic versions now, but I think that the key is having some tool to get at it. The other way to get at these things now is to use one of these validated questionnaires, the asthma control test, the childhood asthma control test, the PEDS AirQ tool. These are validated against diaries. So we know that the scores that people report on them are consistent with what people would say in a prospective diary. So using them to gain a sort of quantitative assessment of asthma control, I think is often pretty helpful. I think that really does help get around the burden of asking people to keep a diary, which in my experience has been pretty unhelpful for the most part.
Okay. Well, thank you, Dr. Baccaria, for such an insightful and engaging presentation today. And thank you to all of you for joining us. We hope that this session has provided valuable tools and strategies to support your practice in the management and treatment of complex asthmatic patients. In a few days, Zoom will email you a link to this recording, supplemental resources, and a post-webinar evaluation. Your feedback is very important to us, and it helps to shape future programs. Join us next month for another Advances webinar on April 16, 2026 at 4 p.m. Eastern Standard Time as Dr. Clint Dunn presents chronic urticaria, antihistamines, biologics, and BTK inhibitors. On behalf of the Allergy and Asthma Network, thank you again for your presentation. We look forward to seeing you at our upcoming webinars. Have a wonderful rest of your day.